Assalamu alaikum wa rahmatullahi wa barakatuh. Now we are going to start the last session, high risk pregnancy master class. Now we are going to present PREM 5, the most relevant care in relation to preterm delivery. Professor Bojar Corporation, Sweden. Okay, you can start.
Thank you very much, and thank you for the kind invitation from the organization ASOGIC 27, and I'm very happy to be here. I'm going to speak to you about effective and very simple intervention that we can do to improve the outcome of preterm infants worldwide. We called it PrEP 5. I'm an obstetrician, I'm a gynecologist, I'm working with high-end genetics and really working and publishing data on genomes for the gestational duration and preterm delivery, and we have published that in Nature journals and so on. But there is so much things that we can do really by looking at the simple thing that don't cost a lot of money, that are really very easy to handle in many different ways. So what is it? Yeah, it didn't work. Yeah, it worked now. Thank you, perfect. Yeah. So we, as doctors, we really need to work on all levels, and we should really not only doing the technical work, that means putting together guidelines in different ways, but we should also work with the society in the sense that putting together a kind of whole program that makes the things that we want to do kind of available in the society. But we also need to drive advocacy, outreach, influence the decision maker, the politicians, the civil servants that are on the different that really affects the way of doing. So we decided, instead of going to very high-end things, we wanted to do antenatal to do very simple things that is very cost-effective and it not cost a lot of money. So antenatal corticosteroid is very simple. We also talked about magnesium sulfate. We also talked about very easy thing to do is delayed cord clamping and promote breastfeeding and also using kangaroo care. We call this bundle of activities the PrEP 5, and that is what we really wanted to promote to the society. We all know that preterm birth is the most common reason for death less than 5 years of age, and we also know that we comparing the leading cause of diseases in 1990 and 2019, there have not been any big reduction. It's still the neonatal disorders, and especially then the preterm delivery rates that is really leading that. We produced the Born Too Soon report in 2023 that was launched in Cape Town at the meeting, and we could see that the majority of preterm birth is really happening in low and middle income countries. And we could see that the distribution of death among countries is really, if we're looking at deliveries less than 28 weeks, it is about 12.8 million, and that is really not needed. The high level 3, especially if we look at those babies that are born between 32 and 37, and if we then keep our kind of neonatal level on level 2, we can do a lot for these babies. And therefore we decided, instead of doing very high-end technical recommendation, we wanted to promote some things that really can make a huge difference for us. And that is those that are delivered between 32 and 37 weeks. And it's also very important for us to know that preterm birth is not a problem that will be solved by doctors and midwives alone. It will be solved by a change in society where we need to increase women's education. If we invest in women's education, is absolutely one of the best way to get the better off for the kids and also for the for the family and such. We also need to have more reproductive education. That is both for women and men and boys and girls. And we also need to provide and work very consistently when it comes to access of contraception and safety for women towards gender-based violence and access of healthcare. So there is a lot of things that we can do really that is not related to the labor and birth situation. And we really need to work on all these levels. We need to look at the financing. We need to look at the infrastructure, equipment and commodities, data systems and quality improvement, human resources, referral system and linkage to maternal care, and discharge follow-up and leadership and governments. We need to be active in advocacy and leadership. We need to come together and be on the top of the globe on this. In recent years, many of the care have come together and are put together in models of care, and it can be on the level if it's a very small baby that is delivered on a certain level, but it can also be together with other kind of things when it comes to on the pediatric side with respiratory management, caffeine and prophylactic hydrocortisone. It's a kind of bundle approach that is very common nowadays, and we can make a huge difference by working that way. And WHO is working on that, on PPH and many other issues. We believe that simple intervention can make a significant impact. It's easily taught, it's easily performed, uniformly recommended. Impact on mortality and morbidity, no cheaper and more effective option. Evidence on dissemination includes low and middle income countries also that have been probed by a huge study by WHO when it comes to antenatal corticosteroids. If involved in medication, they are often cheap, they are effective. They are on the WHO list of essential medications globally. They easy store, easy deliver, and minimize the risk of severe side effects. So here they are highly kind of evidence-based, like antenatal corticosteroids. Now also with the most action trial from WHO showing it's working globally between week 24 and 33 plus 6 where they are recommended. Also magnesium sulfate, delayed cord clamping, early breast milk, and kangaroo care. And antenatal corticosteroid is recommended when women in high risk of preterm birth within the next 7 days from viability up to 34 weeks of gestation, where there is concern the course will not be completed, the first dose should still be given. So there are very clear evidence for this. It's not an expensive drug. Start to use it. It's very, very important. And you find all these kind of papers in the FIGO journal, and they are free of access, open access. The other thing is the magnesium sulfate should be given to all women in active preterm labor prior to 30 weeks of gestation. It should be administered over 20 to 30 minutes via peripheral venous cannula. If cannulization is not available, you can give 4 grams over the last 5 minutes intramuscular in the buttock. Where possible, this can be followed by 1 gram per hour continuous infusion up to 24 hours. So this is very important to do if you have a baby that is about to be delivered less than 30 weeks of gestation. Also, when it comes to delayed cord clamping, it's very simple, easy to do, and should be offered to all preterm born infants. The only medical exception are those where there is no fetal heart rate or a member of staff can provide resuscitation, and where the mother requires immediately medical attention, like the postpartum hemorrhage. And it's easy to practice, it's easy to be done. The other thing that we need to work on, and is really low-hanging fruit, is breastfeeding. Infant feeding should commence within 1 hour of delivery wherever possible, and the first fed should be breast milk. And it's very, very important and very simple to do. The other thing that have turned out to be very, very effective and very clear, actually with the strongest data to support this, is kangaroo care. Kangaroo care should be offered as part of the care of all preterm infants. It should be offered continuously and commence within only a couple of hours. The only reason to delay commencing kangaroo care are that baby is not breathing immediately after initial resuscitation, if there is a hemodynamically unstable situation, or it should be mechanically ventilated. So all these three things is very simple, and imagine that you can do kangaroo care from 1 kilo and up, and it in the WHO study published in New England Journal of Medicine in 2020 showed that there was a reduction of neonatal death with 25%. So simple, so little cost. There is a huge possibility, and therefore we decided to promote this stuff instead of saying a lot of other things. There are other things that we can also do to promote, to reduce the burden of preterm delivery. I listened to the session here before. Single embryo transfer by the reproductive doctors is very effective. The other thing is not to do in preterm delivery if we don't have any strong indication for that. So in the FIGO working group of preterm delivery, PrEP 5 is one of the most easy, simple, and cost-effective things that we can do. We have also done various issues here on infographics that we have on the FIGO homepage. You can take your phone also to see the video that we produced to do this kind of very simple training that can be used as long as you understand English. There is a huge possibility to do this. And also we are working on translation, dissemination, and there will also be as kind of second intervention here. So here you have the video. You can find it on YouTube, and so it's very easy to access. And that is what we want to do in FIGO, and in the division of maternal and newborn health. We do several of these kind of simple dissemination. Even if we are expert on high technical things, we understand that these is easy things that can be very easily handled in many ways. Thank you very much.
Thank you, Professor Jacobson. Any question from the floor? Okay, thank you.
Thank you. Thank you.
now introduce طبعا استاذ الاجيال اللي هم استاذ الدكتور صبحي ابو الوز. عنوان التوك ان شاء الله يبقى optimizing safety during placenta creta spectrum management.
بتكلم على الفروض. طيب ماشي اوكي حاضر. هنرجع تاني بس يعني كده يمين وشمال بس. اوكي طب ماشي حاضر اوكي خلاص. شكرا. مساء الخير الاول. طبعا الجلسه الاخيره ديت يعني بتبقى مرهقين، لكن انا عايز اقول لكم حاجه. الاوبستريكس از بلادي ديسيز. بلادي ديسيز يعني احنا بندخل واحنا قلقانين مش عارفين هنعمل ايه. من مشاكل البلادي ديسيز ديت وهي وجود البلاسينتا في مكان غير طبيعي بتاعها. بلاسينتا بريفيا اكريتا او انكريتا او بريكريتا او كلهم مع بعض. The incidence of placenta acrita has been increased. زادت ليه؟ عشان القيصريات زادت. فانسيدنس زاد حوالي 10 to 15 برسنتج. وايضا في مشاكل كثير جدا بتترتب على هذا الوضع. مشيش ليه يا بنتي؟ ما بتتحركش ليه يا ابني ده؟ It is reported to have a mortality rate of around 7% and is the most common indication for birth-related hysterectomy. Mortality rate يعني بيموتوا الناس. السيدات بتموت والدكاترة في panic situation في مثل هذه الحالات. High risk the association between placenta previa and placenta acreta. يعني لو كانت العيانة ديت placenta previa وجه بعدها placenta acreta الاثنين دول double complication. دايما بتيجي بعد قيصريه او بلاسينتا بريفيا لوحدها. بلاسينتا بريفيا itself raise the risk for accreta due to implantation over a highly vascular, poorly contractile lower uterine segment and existing scar in the same area as well obviously complicated and increase the problem. The PAS as a disease resulting from combination of many factors: defective decidua, abnormal trophoblastic attachment, abnormal angiogenesis, and vascular remodeling and progressive uterine scar dehiscence. أحسن تشخيص للبلاسينتا أكريتا وتوابعها is the trans vaginal ultrasound. طبعا كلنا بنبدأ الأول التراساوند abdominal، ولكن ترانس فاجينال هو التشخيص الدقيق الصح. طبعا ده مهم جدا. عشان كده احنا بنقول دايما السونوجرافر از ديسيجن ميكر. هو هيقول لنا هي دي بلاسينتا اكريتا ولا لا، وهي تحتاج تدخل سريع ولا لا، وايضا يحدد لنا المكان. لدرجه انهم دلوقتي بيعملوا ترانس فاجينال التراساوند ديورنج ذا اوبريشن، وبعد الاوبريشن ايضا بيعملوا الترانس فاجينال التراساوند. loss of retroplacental hypoechoic zone, progressive thinning of the retroplacental hypoechoic zone, presence of multiple placental leaks. Placental leaks دي مهمة جدا. thinning of the uterine serosa bladder wall complex and elevation of the tissue beyond the uterine serosa. دخل معانا مع الالتراساوند كلر دوبلر. كلر دوبلر ده اساسي اساسي اساسي، واللي ما عندوش كلر دوبلر في الالتراساوند بتاعه يحاول يجيب جهاز او يبعتها لوحدة الالتراساوند عندنا في جامعة عين شمس. Color Doppler sign suggests of placenta accreta dilated vascular channels with diffuse lacunar flow. Dilated vascular channels with diffuse lacunar flow دي مهمة جدا. Irregular vascular lakes with focal lacunar flow, hypervascularity linking placenta to bladder, and dilated vascular channels with pulsatile venous flow. البلاسينتا فيها increase vasculation في المنطقة دي، ولما تبقى اكريتا او انكريتا الفاسكولاريتي بتزيد اكتر والكوميونيكيشن بتزيد اكتر. دوبلر التراساوند اوف ذا بلاسينتا نورمال زي ما انتم شايفين الصوره الجميله ديت، نورمال بلاد فلو، والابنورمال هو سب بلاسينتال هايبر فاسكولاريتي بريدجنج فيزلز اند لاكولار فيدنج فيزلز. اهم حاجه البريدجنج فيزل ديت خطيره جدا لان اللعب فيها مش كويس. برضه الصوره من الصور الجميله كلر دوبلر التراساوند. دايما السونوجرافر يقول لك ايه، انا شايف الصوره بتاعتي هنا في عندي فاسكوليتشر عاليه جدا، والمنطقه اللي هي ما بين البلادر واليوترس واضحه فيها فاسكوليتشر عاليه جدا. ساعات الواحد يتلخبط، لكن الحقيقه حتى الان يعني تفسير البلاسينتا ما فيهاش انفيجن، هي عباره عن ديهيسنس اوف ذا سكار. دول فكوا من بعض وبعدوا عن بعض. ما هوش اختراق اساسي. فنيولي فورمد فيزلز اند بلاسنتا ليكس هم دول اخطر حاجتين في البدايه. نيولي فورمد فيزلز اند loss of hypoechogenic area and the uterine segment is shown totally destroyed. Multiple layers of the newly formed vessels مليانه new vascularization كتير جدا. عشان كده اللعب فيها ديت مش مهم، خطير جدا ان احنا ما نقعدش نلعب بايدينا ولا بالمقص ولا بالكهرباء. بيقول لك جنتلمان dealing gently with these vessels. لدرجه ساعات نستخدم احنا الاله نقلبها او نستخدم حاجه اسمها بندق شاش زي بشويش قوي. ده كلام ده طبعا مهم قوي. The newly formed vessels and multiple leaks are very serious. The multiple layers of the newly formed vessels between the uterus and the bladder. Placenta briefly completely covering the internal cervical os with placenta accretum. أنا عايز أقول دي الصورة دي مهمة جدا، بس هي طبعا يمكن مش واضحة كويس أوي هنا على الشاشة. البلاسينتا بتغطي منطقة السيرفكس. The secret of success is to catch the cervix. يعني إيه catch the cervix؟ يعني تدور على السيرفكس من وأنت شغال توصل لتحت خالص، أو من تحت تزقها بالمساعد بتاعك، ويفضل يكون أنت أحسن. طبعا استخدمنا طريقة تانية اللي هي يعني ساعات تفيد وساعات ما تفيدش. احنا طبعا كمستشفى ما عندناش امكانيات الام ار اي في كل حته، لكن الام ار اي ساعات يديني برضه معلومات مفيده جدا ويحدد لي نوع البلاسنتيشن. طبعا ار اي ايمجز بلاسنتا اكريت سبيكترم وايت بين لك الارض دي البيضه دي، ودي البلاسنتا، وده الام ار اي بتاع العيانه دي. المستيتنج كروس انستوموز. هنا في نقطه مهمه قوي. ربنا سبحانه وتعالى عمل لنا ايه؟ انستوموزس. وبعدين الانستوموز ده شانلز فتحت ما بين اليوترس والفاجينا واللاترال بيلفيك فيزلز كلها. هذه الشبكه من الاوعيه للانستوموز دي مهمه جدا عشان ما تخافش ان مهما ربطت من الاوعيه ده فيها ستيل ذير از ا جود سيركيوليشن. في قاعده عامه يقول لك ايه يعني امشي دغري يحتار عدوك فيك. اناتومي از ذا بيزك. اي واحد داخل يشتغل امراض نساء ولاده او جراحه لازم يقرا الاول اناتومي، بروبر اناتومي. اناتومي في اليوترس، ابر سيجمنت، لور سيجمنت، سيرفكس، فاجينا، والبلاد فيسكوليتشر. يعرف اناتومي وبلاد فيسلز اوف ذا بيلفس تمام. ولما تصير في الامتحان تجاوب الاسئله ما فيش حاجه اسمها تصير ارتري وما تعرفش تجاوب الثاني. طبعا شبكه الاوعيه الدمويه دي كل ما زادت معلوماتك اكثر تاخدها بقى من النورمال، تاخدها كاديفر، تاخدها من الكتاب، من اطلس. ده لازم تتعلم كويس قوي. ربنا سبحانه وتعالى برضه ادانا معلومه مهمه جدا. ده is great vasculature بين اليوترس upper and lower segment vagina and the nearby blood vessels. الصوره دي جميله جدا. اليوترس طبعا زي ما انتم شايفين مليان اوعيه دمويه، لكن الخطير جدا ان نشوف البلاسينتا هنا داخله على البلادر وول، وهنا جنب البلادر وول ده اس 1 و اس 2 سيجمنتس عندنا. وده الساجيتال لاين demarcating the S1 S2 areas of the blood supply. S1 دي فوق و S2 تحت، وده مهم جدا. هنا abnormal placentation S1 اللي هي مليانه بلاد فيسلز اللي قدام دي. طبعا احنا لما بنفتح بنشوف المنظر ده بنتخض. اهم حاجه دونت بي بانيك. بانيك سيتويشن يخليك تبقى قلقان وخايف ومتوتر. كول فور هيلب. ونصيحه ليكم لكل الجراحين امراض نساء ولاده زملاتي، ما تشتغلش لوحدك. دونت ورك سنجل هاندد. دايما معاك حد. لو معكش حد لازم معاك فيدباك، واحد يكون جنبك او اقرب حاجه ليك، وغالبا ده ما ينفعش، مش هيرد عليك في التليفون. increase vasculature placenta very vascular. الاوعيه الدمويه هنا very serious blood vessels. كل ده بنشوفه تخض. تشتغل صح. من الحاجات المهمه قوي دايما تفتكرها the bridging of the vessels. demonstrating thick cystic vascular myometrium. دي حاله فيها يعني لقطه جميله قوي. cystic vascular myometrium of a normal of a woman with proven هي كان عندها ادينوميوزس، والادينوميوزس مديني فاسكوليتشر عاليه جدا. وبعدين عملوا هيستريكتومي ولقوا ان النورمال بلاسينتا، وهي ما هياش كاتب بلاسينتا اكريتا، هي الادينوميوزس هو اللي مديني فورس فاسكوليتشر عاليه قوي. بلاسينتا البلج، حتى بتلاقي فاتح البلاسينتا طالعه لك كده بلجنج قدامك، ما تلعبش فيها. placental bulge on the ultrasound scan and after delivery the bulge is caused by loss of structural integrity of the muscle of the lower segment. causing the bulge outward. It becomes more pronounced after delivery at the upper segment when it contracting. uterine dehiscence. زمان كنا بنقول هو انكريتا بريكريتا the placenta is invading the myometrium. الان لا، هي dehiscence اكثر منها invasion. هذا الديهيسنس فك الارتباط او الاشتباك ما بين اللور سيجمنت والابر سيجمنت. فالسكار ده بتفتح ساعات تلاقي العيانه ثين سكار، بنقول ده سكار ديهيسنس. لما يدخل عليه فاسكوليتشر والبلاسينتا له يبقى منظر مرعب جدا. كل ما زاد الفاسكوليتشر كل ما اتخضيت اكتر انت. البلاسينتا البريدجز جاي طبعا زي ما انتم شايفين منظر برضه مرعب. بلاسينتا كريتا از ادهرنت تو ذا ميترم ديت خدوا سكشن باثولوجي. الحقيقه احنا طبعا ما بنقراش الباثولوجي كويس قوي، لكن يعني من ضمن الحاجات اللي هي عايز تاكد انها فعلا كان في ادهيجن او انفلتريشن او انفيجن بتاخد سكشن باثولوجي تبعته. استخدام الالترا ساوند والام ار اي ده في الانتي نيتال دايجنوز. انتي نيتال بلاسينتا اكريتا سبيكترم انتي نيتال فيرست تريمستر سكند اند ثيرد تريمستر. ساعات نشخص بدري قوي بس ما نتلخبطش ونستنى عليها شويه بعد الاسبوع ال 14 لو كان في سكار يقول لك ده سيزيريان سكشن سكار اكتوبيك بريجنسي. اذا هو فعلا ده منظر مختلف جدا. وبعدين فولو اب تجد البلاسينتا طلعت فوق معاك شويه، حصل ديفرنشال جروث والبلاسينتا فوق خالص. ليه احنا بنستخدم الالترا ساوند هنا مانداتوري؟ عشان ده يحدد لنا ديسيجن ميكر بعد كده نتدخل امتى وازاي، يحدد لنا طريقه الانترفنشن وين اند هاو. الام ار اي طبعا من الحاجات الموداليتيز اللي بتفيد في التشخيص، وفي الذات لو كانت البلاسينتا بوستيريور اكتر بتديني معلومات افيد. طبعا مهم اهو. طبعا ده الكلام ده مهم قوي. نشوف الصور دي كلها تقريبيه زي بعض، المنظر مرعب جدا. انا عندي بلاسينتا السيس دي بشوفها، هايدات فورمول بشوفها، سب كونيك هيموريج بشوفه. عندي بلاسينتا الميزنكايم ديسبليزيا دي حاجه من الحاجات النادره جدا وبتدي فاسكوليتشر عاليه جدا. العلاج ميديكال او سيرجيكال او يوتراين باكينج او كونسرفتيف. كل الافكار صح، ممكن تعمل كل الموداليتيز اوف تريتمنت ديت صح. ميديكال طبعا هنشوفها دلوقتي عباره عن استخدام اي حاجه تفيد. ما حدش اشتغل لوحده، اتفقنا مالتي ديسبلينري سكواد with well experience. well experience يعني واحد زميل لك اشتغل شاف الحالات دي واشتغلها مره واثنين وثلاثه في مكان في تيم. النهارده حاجه جميله جدا في جميع تقريبا مستشفيات جمهوريه مصر العربيه وجميع الجامعات الان في فريق بلاسينتا جروب، بلاسينتا تيم. يعني احنا دلوقتي عندنا في عين شمس بلاسينتا تيم في كل الوحدات السته، شباب زي الفل. واعتقد ان الجيل الجديد ده هو جيل البلاسينتا في المستقبل. واحنا الحقيقه كنا زمان بنخاف ونتخض، الان في جرأه عاليه جدا. وهذه الجرأه جت من ايه؟ وجود الخدمات المتكامله. يعني ايه خدمات متكامله؟ يعني مستشفى فيها رعايه للام ورعايه للبيبي، فيها بنك دم وبلازما، فيها مساعدين اليرت اورينتد، فيها تخدير رائع، انستيزيا. وكل ما كان الفريق ده متعاون صح كل ما كان شغلك صح ونتائجك احسن كتير جدا. ممكن نعمل كونسرفتيف بلاسينتا طبعا ممكن نعمل ايه؟ ممكن ندي ميثروكسيل ساعات. طبعا ده يعني في اراء مختلفه عليه. هيستريكتومي. It is better to live without a uterus than to die with her uterus. ما تخافش لو هي محتاجه هيستريكتومي اعمل هيستريكتومي، ما تبقاش قلقان لانك انت هتنقذ حياه المريضه من الاول. انت داخل في نيتك ايه؟ تكونسيرف ولا عايز تعمل هيستريكتومي؟ اذا نيتك داخل من الاول عايز تعمل هيستريكتومي هتلاقي حالك عملت هيستريكتومي. لو نيتك تعمل ان هي كونسرفيشن حاول تعمل كونسرفيشن، بس شروط العلم واضحه جدا. You should go to the anatomy and proper dissection and meticulous dissection and removing the placenta. متاكد انك انت شلت كل حاجه وجود suturing وايفن uterine ligation artery even internal artery ligation. كل الموداليتيز اللي ممكن تعملها لو تعمل كونسرفيشن، لكن sooner rather than later. سيلكتيف ارتيريال امبولايزيشن طبعا ده عملناها مرتين او ثلاثه، كانت معنا الدكتور رانيا والحقيقه يعني برضه استفدنا منها، ولكن عايزه امكانيات وعايزه يعني شغل متعاون فريق جامد جدا. طبعا لازم نتعلم الالترا ساوند صح. والحقيقه الوحده عندنا بتقدم خدمات رائعه تشخيصيه وتشخيصيه جميله جدا في كل وقت احنا موجودين. طبعا دي الزميله الفاضله الاستاذه الكبيره عالمه من علماء بلاسينتا في انجلترا، وهي اللي قالت السكار ديهيسنس از مور اكيوريت ذان انفيجن، مش كده بيه؟ وطبعا سالي ديت مع زميلتنا ديت كانت عندنا طالبه بتتمرن في مستشفى جامعه عين شمس عندنا، واشتغلت معانا حالات وشافت حالات، ورجعت انجلترا مع الاستاذ الدكتور زميلنا محمد خالد الهضيبي، شغاله معاه في انجلترا، وعندهم حاله فيري انترستنت. احنا خلصنا بس احكي القصه دي، قصه جميله جدا. جاء عيانه عندها 40 سنه بلس، عندها وزنها فوق ال 110 كيلو جرام، وبريفيوس سيزيريان سيكشن، وشي هاز نو تشيلدرن، فشي جوت بريجننت، طلعت بلاسينتا بريفيا اكريتا، فتابعوها. جاء في الاسبوع 18 جالها ليبر بين او يعني يوتراين كونتراكشنز جامده جدا، عملوا الترا ساوند قال لك ده البلاسينتا طالعه من اليوترس. فتح محمد الهضيبي الحاله ومعاه الفريق لقى الفاسكوليتشر ديت، لكن اليوترس قال لك ده كويس. هو قالت له انا مش عايز اشيل اليوترس ده بالمره مهما يكن، انا اي وود لايك ماي يوترس. فمضاها ومضى العيله كلها وقفل العيانه والبلاسينتا قدامه وما شالش. وقال لك احنا يعني لها تامين. قاعده في المستشفى وقعدت في المستشفى، فضلت لما وصلت الاسبوع ال 34 خدت الدكسا، وكان متابع معاه الاستاذ الدكتور شريف عبد الفتاح كراجل سينيور، والكونسلتنت بتاع البيدياتريكس والانستيزيا، كل العالم متفقين معاه، وجابت ولد حلو جميل جدا، وعاش هذا الولد، عاش محمد الغضيبي. وطبعا دي سالي معانا هنا في المستشفى. اشكركم ولحسن استماعكم والف سلامه.
بنشكر استاذنا الاستاذ الدكتور صبحي أبو اللوز، استاذنا المدرسه، على هذا الريزوميه الرائع اللي كلنا دايما احنا والله بنمشي جنب دكتور صبحي بيه بنتعلم، مجرد بنعدي يعني بنتعلم. ربنا يخليك لينا ويديك الصحه والعمر يا رب. I should introduce my brother خالد مصطفى كامل. هيتكلم على non alcoholic fatty liver disease. اتفضل يا دكتور خالد.
Thank you very much, Professor Fikriya, for your very kind introduction. I'm going to talk to you today about a medical disorder. It's a medical disorder that affects us as obstetricians and gynecologists a lot. So I'm going to talk about what used to be called non-alcoholic fatty liver disease. The name has changed recently, as I will mention shortly. So non-alcoholic fatty liver disease passes through different stages. The first stage actually is not a disease. It is called simple hepatic steatosis, just a collection of fat within the liver cells. This can progress into something a little bit more advanced, where there is an element of inflammation, non-alcoholic steatohepatitis or NASH. And this can progress to actual fibrosis and cirrhosis, what's known as the non-alcoholic fatty liver disease or disorder itself. And actually sometimes it can be quite severe to lead to even cancer. But why am I talking about this? Because it is a major cause of chronic liver disorders. Actually, in fact, it is now in the Western world the commonest cause for liver transplant. Its prevalence globally is very high, 25 to 35%. So we're talking about 1 in 4 people on this planet have an element of non-alcoholic fatty liver disease. The new name for it, just in case if you come across this, is metabolic dysfunction associated steatotic liver disease, or MASLD. So if you see MASLD or NAFLD, they are actually the same thing. This is the global prevalence. So as you can see, the rate varies from one area to the other. Interestingly, we always hear about sub-Saharan Africa having every single problem on planet Earth. Well, luckily, they are one of the areas with the lowest rates of NAFLD. But NAFLD is quite high in South America, for example. And as you can see, in the Middle East in particular, apart from the rest of Africa, it is actually fairly high. It's one of the highest all over the world. And what happens in this situation, as you move into this slide from left to right, you will see that initially there is some form of fat collection within the liver cells, which does not actually cause a big problem. But some of these cells might start producing pro-inflammatory substances, which in themselves start causing problems to other cells within the liver. One of them are the hepatic stellate cells and something called the Kupffer cells. The Kupffer cells is a type of macrophages that is a resident within the liver. Once these get activated, they release even more substances that start creating the fibrosis and the cirrhosis that happens. And this process can take quite a long time. It can move quickly, or sometimes it doesn't move at all. It just stays at this initial stage of the fatty liver. What are the risk factors for that? There are some risk factors, like any disease we have in medicine, that we can't change. They are non-modifiable. So age is against us when it comes to fatty liver disease. The older we get, the risk becomes higher. Sex, for women, it is protective when they are young, but once they hit the menopause, the risk becomes much higher. And of course, like many disorders in our body, there is a genetic predisposition for it, and there are different polymorphisms that would increase the risk for somebody getting a disorder. There are other risk factors that are modifiable. And interestingly, in the past, we were, as people living by the Mediterranean, protected because we had something called the Mediterranean diet that people now are convincing us to move back to. And the Western world at that time were at high risk of having fatty liver disease, non-alcoholic fatty liver disease, because of the nature of their diet, which is very high in carbohydrate, in fructose, in processed food, things that we did not have actually in our region. The other big problem is the lifestyle, prolonged sitting, sedentary lifestyle. So if we think about ourselves as people working, we actually end up not doing that much activity. We are driving from one point to the other. We are working very long hours. We end up eating really not very healthy food. Our food is becoming more westernized and Americanized, and food coming from South America and all sorts of things, and our natural food is becoming less and less. The other big reason for NAFLD is obesity and metabolic syndrome. These are very, very much associated with it, especially with regards to the insulin resistance that happens within that. If we agreed that the risk for NAFLD in the general population is about 1 in 4, 25%, for people who are actually obese or morbidly obese, the risk of having NAFLD is 90%. So 9 out of 10 obese or morbidly obese people will actually have an element of a NAFLD. And this seems to act in two different ways: as an initial stage in producing the fat that goes into the cells, but later on also in increasing the chance of progression of this NAFLD from the NAFL to the actual disorder. And then there is another big player now, and this is a paper that we've recently published in BJOG about the effect of environmental toxicants, pesticides, insecticides, and we have a lot of this. Each one is living in a compound. They ring complaining that people who are going to spray the mosquitoes have not passed up till now. We want more mosquito spray. And this is actually something that is harming us and harming our children, but we don't really think about it, because all what you're thinking about is we want to sit in the garden and not have an insect prick. Most of the substances that go into the synthesis of plastics, and actually the plastic itself in bottles, that's why people in the West now are moving away from drinking water from plastic bottles, because these plastic particles stay there and go into our body. And these toxicants accentuate both the initiation and the progression of NAFLD. So how is it diagnosed? The initial stage can be diagnosed on ultrasound scan done by somebody who knows what they're looking for, and they can see liver cells. But this does not, liver cells with fat within it. But this does not actually tell us whether there is a disorder or not. And the only way for us to know that the disease has progressed is actually by doing a liver biopsy, which is quite invasive and intrusive. And certainly it's not something that we're going to do for everybody on planet Earth. So now I'm going to focus in the part related to our specialty. And there are three conditions that are very much linked to NAFLD from our point of view. One of them is polycystic ovarian syndrome, the other one is pregnancy, and the third one is menopause. The one on the left-hand side happens to a lot of women. The pregnancy happens to most women, and the menopause hopefully happens to all women, that they live long enough to reach the menopause. So there are things that are very common in our specialty. We know this vicious cycle of polycystic ovarian syndrome. Nobody knows where it actually starts, but we know that the process starts somewhere and becomes worse and worse. But we also know that not every PCOS patient, even if she is diagnosed with the full syndrome, is actually quite resistant to treatment. And not every one of them is going to run into problems. But some of them have really quite a severe disorder that you seem to have difficulty in managing it and controlling it, whether they're coming to you for fertility reasons or to reduce the risk of miscarriage or risk of stillbirth or whatever is happening. And not every PCOS patient will also develop insulin resistance and diabetes, but some do. And it seems the severe forms of this PCOS is very much linked to the non-alcoholic fatty liver disease and the metabolic syndrome, to the extent that women who have PCOS, the risk of having NAFLD is more than doubled compared to somebody who does not have that. And for women who have PCOS and confirmed NAFLD, all the risks, particularly cardiac disorders, is much higher than somebody who does not have both conditions at the same time. How do we manage it? Of course, lots of people give metformin to anybody with PCOS. Unfortunately, although metformin has been demonstrated to lower the fasting glucose, it does not seem to have an impact on body mass index. And when it comes to its effect on steatotic hepatitis, NASH, or NAFLD, there is some evidence from observational studies it might have a benefit. However, this has never been confirmed in a randomized controlled trial, which is our gold standard. There is a newer medication available for us, which is a glucagon-like peptide-1 agonist, and this seems to have a potential in controlling NAFLD within the context of PCOS. However, the most important thing, which is something we've always known about, is lifestyle modification. We have to give it much more attention. The patients need to understand the importance of that. It's not just a matter of saying it, but actually people don't change what they're doing. Pregnancy, there are lots of liver disorders associated to pregnancy. I'm just going to focus on NAFLD. And within NAFLD, of course, the prevalence is higher in women who are older at the time of pregnancy. For women between 20 and 40, 1 in 10 of your patients will have a non-alcoholic fatty liver disease. In Egypt, it's probably a little bit higher. These are figures from the West. And it's the chances that NAFLD will be there will be higher if a woman has high body mass index, which is a global problem everywhere, and certainly I'm sure it is also a case in Egypt. If the woman is known to have some form of a metabolic syndrome, insulin resistance, or indeed if she already has diabetes mellitus, then her risk is much higher. The presence of NAFLD will increase most of the disorders we are talking about in obstetrics. So at the beginning, at the outset, you're aware that this woman is at a much higher risk than anybody else for developing preeclampsia. Her risk for cesarean section, although the fact that she's in Egypt or in the private practice, her risk will be much higher anyway if she doesn't have NAFLD, but this is a different argument. The risk of preterm birth and the risk of the baby being born small for gestational age. I mean, this is really very basic, but somebody with any degree of insulin resistance, the baby itself will have lots of acute problems like shoulder dystocia, birth injuries, postnatal hypoglycemia. But the biggest problem that we have to think about is that a mother who has NAFLD, her offspring's risk of developing NAFLD is then much higher. And we should really make sure that patients understand this, because the biggest driver for people being healthy or changing their lifestyle is actually to protect their children rather than to protect themselves. So it's an important piece of information. And this transfer of NAFLD from mom to baby seems to be happening at an epigenetic level, not changing the genes themselves, but the epigenome. And these are changes that happen to the DNA methylation that can switch some genes on or off at a very early stage when this fetus is still being developed. This is a very interesting cohort, the Rhine cohort. It involved nearly 3,000 live-born babies, and they followed them for 17 years. They found that the risk of NAFLD in this population was about 15% in their adolescent years. But interestingly, they found that one of the very protective things for these babies from developing NAFLD in their teenage years later on is if they were breastfed or not, if they were breastfed for more than 6 months. It's a piece of information that is very important for mothers who are not are thinking of not breastfeeding or introducing formula milk early or introducing solids early. And these are the different interventions also that could affect the risk of NAFLD for these babies, whether the use of supplementary milk, introduction of solid food, or breastfeeding. And you can see on the left-hand side, this is the prevalence of NAFLD, and the prevalence of NAFLD will reduce the longer period of time the mother breastfeeds the baby absolute breast milk rather using anything else. This is in relation to the same thing, again relevant for us when it comes to pregnancy, is the risk for the offspring developing NAFLD. And this is an animal study on mice, and they got some mice, gave them high-fat diet throughout the pregnancy. Their offspring ended up with high risk for NAFLD. The ones who had a normal diet throughout, the risk was very low. The ones who had high fat, and then just before the pregnancy, 1 week before they stopped that, the risk was still high. Only the mice where the lifestyle and the food has changed for a mice pregnancy, which is very short, 9 weeks before they even got pregnant, that you were able to revert this risk. So pre-pregnancy counseling and the patient altering her lifestyle and diet quite a few months before she gets pregnant is very important. And this is really our role. Our role is not only to see mothers when they are pregnant, but to prepare them for the pregnancy. So NAFLD is also a life cycle when it comes to the transmission to the offspring, and there are only 2 points that we can cut. One of them, we can interfere with this cycle to cut it. One of them is just before the pregnancy, if we're able to make sure the mom is healthy for enough period of time, definitely at least 6 months before she embarks on a pregnancy. And you can also reduce the risk after delivery by making sure that this baby at least gets enough breastfeeding. The last slide is NAFLD and the menopause. I told you the risk for men is higher than women. However, after menopause, this reverts, and the risk for the woman becomes much higher. In Egypt, we have a huge concern about use of HRT and the menopause, but it's something that we really have to take into account, especially for somebody at risk of NAFLD, that maybe HRT is one way of reducing this risk if the woman wants to carry on with a healthy lifestyle. So in conclusion, NAFLD is a common chronic liver disease with rising prevalence. It's not commonly known outside the field of hepatology. It's something that we don't think a lot about. We know the name, but actually we don't give it much attention. NAFLD has a significant impact on the woman and her offspring, her children, and there is no medication currently licensed for that or its prevention, and lifestyle and dietary intervention is probably the best thing. And from a public health point of view, we have to be more aware of the environmental toxicants around us. Thank you very much.
Thank you very much, Professor Khalid. If anybody has any question. Okay, next I'm happy to introduce Professor Muhammad Kamal. Professor Muhammad Kamal is Professor of Obstetrics and Gynecology in Fayoum University. He's the head of the Egyptian Fetal Medicine Association. And of course, he's a very dear friend, and hopefully we will know by the end of this lecture whether the third trimesteric scan is worth it or not.
Thank you. Assalamu alaikum wa rahmatullah. Thank you, Dr. Karam, for your nice words and introducing me. بشكر طبعا كل حضراتكم على الحضور. وأصعب حاجة هي آخر محاضرة في يوم شق زي ده وقبل العشاء يعني. إن شاء الله مش هطول وهنحاول نسمرايز المحاضرة سريعا في points يعني. In this lecture, I try to summarize the ASOGIC guideline, which one of the recent guidelines released from ASOGIC about the importance of third trimester ultrasound scan. The items I will talk about: the timing indication for ultrasound scan third trimester, fetal anomalies, placenta previa, vasa previa breech presentation, and abnormalities in fetal growth, role of ultrasound in this time for assessment of fetal growth abnormalities and amniotic fluid volume. As regard timing, what we mean by third trimester is ultrasound in between 32 to 36 weeks, and for estimation of gestational age, if the patient does not have accurate date, we can depend on head circumference alone or head circumference with femur length. But as regard estimation of fetal weight, we depend on head circumference, abdominal circumference, and femur length. Also, it's important in this period to assess fetal well-being in the form of umbilical artery in high-risk pregnancy, and if there is any abnormalities, we use middle cerebral artery, uterine artery, and ductus venosus, especially in fetal growth restriction. In this time, we assess fetal viability, presentation, anatomy, and growth scan, amniotic fluid volume, placental location, and exclude or diagnose BAS, assessment of gestational age and postpartum bleeding. If there is any complaint from the patient about reduced fetal movement, rupture of membrane, or suspect any abnormalities in fetal growth. One of the most important in this period is some or a lot of fetal abnormalities cannot be detected easily in second trimester, and the reason due to maybe maternal obesity, increased BMI, fatty abdomen, scar, and so on. But it's very important to notice that around 4 per 1,000 women with fetal anomalies diagnosed only in third trimester, especially in genitourinary tract, central nervous system, and heart. وبالتالي ده very important كميديكو ليجال ان لو في حاجه ميزد في السكند ترايمستر واتشخصت في الثيرد ترايمستر او افتر ديليفري بالجايد لاين ده احنا شايفين ان الجينيتورينال تراكت والسي ان اس والهارت اراوند من كل 1000 في 4 بيتشخصوا في الثيرد ترايمستر نوت ان سكند ترايمستر. طب ايه البينيفيت؟ لان ده سؤال مهم جدا. طب انا هعمل الثيرد ترايمستر سكان، ايه اللي هيطلع لي وهي خلاص هتولد؟ اول حاجه arrangement of the place of the birth, very important. Arrangement with the neonatology and the neonatal ICU. Another point is allow the parents time and the counseling to prepare themselves that they will have a child with anomaly. Also, if there is chance to or choice, we can do genetic analysis. Another plan for follow-up, neonatal follow-up, time of delivery, if it is possible for termination of pregnancy, if we diagnose a case of incompatible with life, and evaluation of head and brain, chest, abdomen, urinary system. All of these are important in third trimester. As regard this image, in this the left image is a normal head, but sometimes in third trimester, just we discover that there is ventriculomegaly, especially maybe there is irregularity or calcification in the wall of the atrium, which indicate hemorrhage or infection, malformation of vein of Galen, microcephaly, especially microcephaly diagnosed in third trimester. As regard to heart, assessment of the situs, the size, the symmetry, the four-chamber view and outflow tract is very important to assess the CT ratio of the heart, and if there is some asymmetry in the ventricle or in the size of the artery, a pulmonary larger than aorta, is accepted in third trimester. Another very important point for medical legal that around 20% of congenital diaphragmatic hernia also detected in third trimester. يبقى دي نقطة برضو مهمة، لأن في حالات كتير بنشوفها diaphragmatic hernia after delivery أو قبل الدليفري، وبتبقى عاملة انومالي سكان في السكند ترايمستر، وده برضو كميديكال ليجال دوكيمنت بالنسبة لنا إن around 20% من الحالات دي بتشخص إلا في الثيرد ترايمستر. الابdominal abnormalities in the form of fluid collection, calcification, cyst, especially bowel atresia and bowel dilatation. Usually abnormalities in bowel in the form of atresia commonly seen in third trimester, late third trimester. Urinary system, as regard analysis by a lot of papers and researches, around 60% of cases of hydronephrosis detected in third trimester. Another point, second trimester everything is good, but we discover in third trimester that there is hydronephrosis, and when we measure the renal pelvis anteposterior diameter and exceeds 7 millimeter, it means there is dilatation, and if this dilatation exceeds 15 millimeter, it means that there is a risk of postnatal intervention. One of the very important item in the third trimester for diagnosis and screening of ultrasound by ultrasound is diagnosis of BAS. Especially when we found placenta previa in second trimester, it is recommended to ask the patient for follow-up, especially if there is previous history of scar, to start from 28 weeks for early diagnosis of placenta accreta and other abnormalities. Vasa previa, as you know, it is fetal vessels traverse the membrane overlying the cervix or within 2 centimeters from the internal os, and by transvaginal ultrasound, it's clear and easy to diagnose it to save the fetus from morbidity, from mortality, and the survival rate in this case is 100%. محتاج اعمل shift. Okay, sure. Breech presentation, it's very important to assess the presentation before delivery or at time of delivery to exclude breech presentation. One of the very important is fetal growth abnormalities, especially the large for gestational age, to avoid the complication of delivery. And the large for gestational age, it means that estimated fetal weight or abdominal circumference exceed 90 percentile. And the macrosomic is at term, it means that the fetal weight exceed 5,000 grams. Large for date diagnosed at 36 weeks is more accurate than in 32, and also in case of fetal growth restriction, late onset fetal growth restriction, we discovered that the sensitivity and the accuracy of detecting fetal growth restriction at week 36 is better than at week 32, and it's very important to diagnose before delivery. Abnormalities of amniotic fluid, we measure amniotic fluid in the form of amniotic fluid index or deepest vertical pool, and it's better to use amniotic fluid index in case of polyhydramnios, while deepest vertical pool we use it in case of oligohydramnios or fetal growth restriction or in routine examination. Just we need to measure one vertical pool. There are several causes of oligohydramnios in the form of idiopathic, rupture of membrane, FGR, urinary system, and also for polyhydramnios like idiopathic, maternal diabetes mellitus, GIT abnormalities, CNS, placental tumor. All of these we have to exclude before delivery. Take-home message. Systematic assessment of the impact of routine third trimester ultrasound examination has provided robust estimates of its diagnostic accuracy for fetal anomalies, small for gestational age, large for gestational age, and any abnormalities, as well as some adverse perinatal outcomes. Thank you.
Thank you very much, Professor Muhammad Kamal. Do we have any questions? Okay, that's Dr. Usam.
I want to ask about vasa previa. Is it possible to determine or to discover abdominally? As
it will depend on it will depend on the fetal presentation, the presence or absence of scar in the lower part of the abdomen, the obesity. But it's better if you are in doubt, especially if the patient complained several times for spotting bleeding. You can do it by transvaginal ultrasound, and the transvaginal ultrasound is safe in case of placenta previa or in vasa previa.
Yeah, in case of suspicious only, it will be okay. Thank you, sir.
My pleasure.
Okay, this concludes our session and our day, I think. Thank you very much for attending.